My name is Drew Johnson, and I'm a PGR1 pharmacy resident at Emory University Hospital in Atlanta. My project is titled Timing Evaluation of the Initiation of Thiazide-Type Diuretics, or TIMIT, for Sequential Nephron Blockade. I have no disclosures. Acute decompensated heart failure accounts for about 1 million hospitalizations annually. Treatment is guided by assessment of fluid status and perfusion. Specifically, fluid management is typically achieved through IV loop diuretics. However, over time, through a variety of mechanisms, patients experience reduced urine output and a phenomenon termed diuretic resistance. Sequential nephron blockade describes the practice of administering diuretics with differing mechanisms of action, typically thiazide-type diuretics, to produce a synergistic diuresis. The general recommendation is to administer thiazide-type diuretics at least 30 minutes prior to IV loop diuretics. However, limited literature supports this recommendation, and instead it is based on the theoretical optimization of the agent's pharmacokinetic relationship. The purpose of this study was to evaluate the optimal temporal relationship of thiazide type and loop diuretic administration in the implementation of sequential nephron blockade in acute decompensated heart failure patients. This was a retrospective crossover study. Patients were adults with heart failure admitted to Emory University Hospital and located in an ICU or cardiology nursing unit between January 1st, 2019 and July 31st, 2020. Data were obtained via Emory Healthcare Data Warehouse. Our study included patients who were loop diuretic resistant, defined here as previous administration of loop diuretic with subsequent intensification with sequential nephron blockade. Patients had to have been administered each timing strategy, receiving either furosemide or bumetanide, amitelazone or chlorothiazide. Some exclusion criteria consisted of utilization of loop diuretic continuous infusion, lack of urine output quantification, different thiazide agent or diuretic doses, or initiation of renal replacement therapy within 48 hours. Logistics-related exclusion criteria consisted of loop, chlorothiazide, or metilazone administration less than or equal to 6, 8, or 24 hours, respectively, prior to sequential nephron blockade, loop or thiazide-type diuretic administration less than or equal to 6 hours following sequential nephron blockade, or greater than 48 hours between interventions. As mentioned, this was a retrospective crossover study. Patients were first identified as loop diuretic resistant. Patients subsequently received sequential nephron blockade with one timing strategy, either thiazides less than 25 minutes or greater than or equal to 25 minutes prior to IV loop diuretics. 25 minutes was chosen as the timing cutoff to account for thiazide-type diuretic administration occurring non-clinically significantly prior to 30 minutes. Following the first administration, patients then crossed over and were administered sequential nephron blockade with the other timing strategy. The outcomes between the two timing strategies were compared. The primary outcome was 6-hour total urine output. Secondary outcomes included 6-hour hourly urine output, 6-hour total urine output in chlorothiazide or metilazone exclusively treated patients, and safety outcomes of hypokalemia, hypomagnesemia, hyponatremia, and hypotension. It was determined that inclusion of 74 patients would provide 90% power to detect a 250 milliliter difference in 6-hour total urine output. Paired t-test or Wilcoxon sign rank test compared continuous variables, while McNamara's chi-squared test compared categorical variables. Of the 195 patients meeting inclusion criteria, 116 patients were excluded, and 79 patients were eligible for further review. The most common reasons for exclusions consisted of patients receiving metilazone less than 24 hours prior to sequential nephron blockade, patients on a loop diuretic continuous infusion, or greater than 48 hours between interventions. Our study included primarily patients with reduced ejection fraction at about 70% of patients. Only 73% and 20% of patients were on a loop diuretic and thiazide-type diuretic, respectively, as an outpatient, which is lower than expected. About 18% of patients were on an IV inotrope as an outpatient, and about 8% of patients had a ventricular assist device. At baseline, patients were somewhat hypokalemic, which potentially predisposes to further hypokalemia. BNP was elevated on average, which may indicate fluid overload in patients with reduced ejection fraction. The vast majority of patients received high-dose furosemide, and our institution caps furosemide bolus doses at 200 milligrams. Furosemide equivalents of patients receiving bumetanide were calculated as 1 milligram of bumetanide equals 20 milligrams of furosemide. Most patients received chlorothiazide, whereas few patients received metelazone. The majority of chlorothiazide doses were 500 milligrams, and all metelazone doses were 5 milligrams. There appeared to be a difference in the interval between thiazide type and loop diuretic administration between the groups, as there was a median interval of 40 minutes when the thiazide type was administered greater than or equal to 25 minutes prior to the loop, in comparison to 0 minutes when the thiazide type diuretic was administered less than 25 minutes prior to the loop. The table and graph display the primary and secondary efficacy outcomes comparing thiazide type diuretic administration greater than or equal to 25 minutes versus less than 25 minutes prior to the loop. The difference in the primary outcome, 6-hour total urine output, was not statistically significant at 1,382 versus 1,310 milliliters. In patients receiving exclusively chlorothiazide, 6-hour total urine output was 1,362 versus 1,320, which is also not statistically significant. There was numerically larger 6-hour urine output with thiazide pre-administration in the 5% of patients receiving metelazone at 1,929 versus 898 milliliters, but this was not statistically significant. There were no significant differences between the two groups at each hour following sequential nephron blockade administration. There were also no significant differences in hypokalemia, hypomagnesemia, hyponatremia, or hypotension between when thiazide type diuretics were administered greater than or equal to 25 minutes versus less than 25 minutes prior to the loop diuretic. Our study has several important limitations. First, the retrospective nature of the study relies on nursing documentation, which impacts both administration times and quantification of urine output. Urine output is also based on a single administration rather than an average of multiple administrations. Additionally, this is a single center study, so results may not apply to different institutions with different clinical practices. Finally, there was a low inclusion of patients taking metelazone, which limits applicability of findings to this population. In conclusion, this study found no clinically meaningful difference between thiazide type diuretic administration greater than or equal to 25 minutes versus less than 25 minutes prior to loop diuretics. A numerical trend towards a benefit to pre-administration was seen in the metelazone group, which may warrant further investigation. I would like to acknowledge my co-investigators, Dr. Kayla Nichols and Dr. Stuart Hurst, for their support in this research. Here's my objective, assessment question, and answer. Thank you for listening. Please reach out with any questions.